Thanks, Amy. Let me just share my presentation. Looks good. Okay, great. So thanks everybody for coming and joining me outside our virtual department. And thanks for the great talk so far. So yeah, as introduced, I'd like to talk to you today about my research. And I'm a PhD student, by the way, at the University of Cambridge. And my research focuses on how we can understand and improve fairness within medical risk prediction. So this applies to polygenic scores, but also any type of medical risk prediction algorithm. So firstly, it probably makes sense to describe what are medical risk prediction algorithms. And so what they do is they combine lots of different types of data. So this can be things like medical records, demographic information, genetic data even, and they can provide personalized predictions of people's risk of getting a disease. And what these can be used for is to help make decisions on who should be screened, what preventative measures people should have, and what kind of treatment people could have. And this can be done before somebody even gets sick. So really, these kind of tools have the potential to revolutionize healthcare, really. They could influence policy and obviously save healthcare systems money. And most importantly, they can prevent illness as well. But it's very important that these tools also are actually fair for everybody and that they can provide equally good predictions for everybody. And this is so that everyone can receive equitable medical treatment, of course, regardless of things like sex, ethnicity, age, or socioeconomic background. However, like these algorithms are great and they work well so far, but some of them don't necessarily perform that well for every group of society. And so one example of this recently is that DeepMind brought out a new AI prediction tool that could predict kidney injury 2 days before it happened, which of course is fantastic. However, it didn't really work for women. And obviously this is less fantastic. And so really, before we can understand how these tools are unfair, we must understand what fairness actually is. And so unfortunately, society and humans are unfair themselves, and discriminatory decisions have been made by humans. But really what we can do with these algorithms is improve these problems, and we don't need to be making them worse. So the area of research that looks at this is called algorithmic fairness. And this is an area that comes from computer science. And what it does is that it makes sure that predictions that are made by algorithms don't benefit some people while negatively impacting some others. So for example, they could be missing diagnosis in one group, like we saw for the kidney disease example. And so really the goal of algorithmic fairness is to make sure that algorithms' decisions are more fair than those that would be made by a human. But really, to understand this even more, we need to understand what causes these aspects of unfairness within the algorithms before we can figure out how to fix it. And so really there's two ways that unfairness is caused. And so the first one is that the data that is used to develop these algorithms is actually biased. And really, this is because it may not represent society or the population for which the tool is built. And this is usually due to things like historical societal biases, issues with data collection, which results in a lack of representation of some types of people within the data. And so really, the predictions that can be made are only as good as the data that we have. And so really, it's not the algorithm's fault. It just doesn't know how to predict for people who it hasn't seen before and people who are not similar to those that are in the data that it is made with. And so unfortunately, this is more likely to affect minority groups. And then the second way that unfairness can be caused is that the algorithms can kind of perpetuate existing biases. And how this works is because the algorithms are programmed to ignore uncommon cases, because this the priority is really to make them simple and fast. And for example, if you go into a GP surgery and they apply all of your information into one of these risk tools, you wouldn't want to be waiting hours to find out your results. And so this means that to make the models simpler, they can ignore minorities. And really, these algorithms are designed to have a high overall accuracy, and they generally do. However, this doesn't mean that the accuracy is quite as high for every group. And so now starting to think about how we can assess whether a tool is fair, and then, of course, how we can improve it. So really, the ideas from algorithmic fairness say that we can measure fairness using lots of statistical and mathematical ideas. And the way that these work are that they analyze the differences in prediction for different groups of society. So this could be sex or ethnicity or age, for example. And what we've been working on is how this can be done within cardiovascular disease risk prediction algorithms, because this is a popular area in which these kind of tools are already used. And so cardiovascular disease is one of the main causes of death in the UK, unfortunately. However, it is actually often preventable. And cardiovascular disease has clear risk factors. So these can be things like lifestyle information, whether somebody smokes, whether they have high measurements in terms of cholesterol, or maybe if they've got diabetes, if they have a family history, and these kind of things. And these tools are actually already used within the clinic, and they work very well to identify who might be at high risk of developing cardiovascular disease in the future. And so what these tools do is they predict the risk of a patient having what we call a cardiovascular event. So this is something like a heart attack or a stroke, and this is within a given time period that they predict for. But what we can do using medical data is follow patients over many years, and we can see that if the patients were predicted to have a cardiovascular event, what actually happens in the future, and is their outcome the same as what the algorithm predicted. And then we can use the measures of algorithmic fairness that can measure whether the predictions are less good for some groups or individuals. And so I'll just give an example here in a moment. So if we say have 3 cardiovascular disease risk prediction algorithms, and they work well, but we have a suspicion that they may not perform equally well for everybody. And so what we can do is split the population into groups, and then we can compare the predictions for the different groups and see how these align with what we actually see happen to these patients, called the observed events. And so we can see at time 0, we can say what percentage of the people in this group do we expect to have a cardiovascular event, so be categorized as high risk within a 10-year period. And then we can look at, after 10 years, what happens to these people, what percentage of the people in this group actually experienced a cardiovascular event. And we can then use this to assess the fairness. So here I have some plots for 3 different cardiovascular prediction algorithms. And so each of these blobs is a different type of algorithm. And then we see on the x-axis the predicted percentage of people within a group who are expected to have an event. And then on the y-axis is who actually has an event. And so if the algorithms were perfectly accurate, then they would, all the blobs would be along the central diagonal line. And so actually for these tools, what we see overall is that they are very close to the diagonal line. And in the first plot here, which is the white ethnicity group, they're quite close to that line. But for the middle plot, we see this is for the East Asian self-reported ethnicity group. they're actually significantly over predicted. So we see that the events that we observe are actually a lot less than what is predicted. And so that means that all the plots are underneath the line here, which is obviously less good. And then if we look at the South Asian ethnicity group, we see that most of these are actually under predicted. And so these people are more likely to experience a cardiovascular event than what the algorithm predicted. And so it would be deemed more fair if there was a lesser difference between these. And really both are bad. You know, we don't want people to expect to not be at high risk and then they go on to have a cardiovascular event when actually they could have been, it could have been prevented. And then similarly, it's not great to say that people are likely to have a cardiovascular event and then they actually don't turn out to be as at high risk, and then they prescribe things unnecessarily or experience emotional stress because of this. But really, speaking about, so this is one way we can kind of look at fairness and measure fairness, but there's lots of different definitions and lots of different ways that we can do this. And I'm just going to give you a couple of examples that kind of illustrate the idea that it's not necessarily clear which definition of fairness is most appropriate and how we should measure it. And so there's a definition called equal opportunity, and this says that we would want the same percentage of cardiovascular events to be predicted for all groups, which sounds quite a reasonable thing. But then it may not actually work in this context. So for example, if we looked at two different groups, if we split the population into sex of male and female, we would actually see that the average risk for a woman of the same age is less than that of a man for the same age group. And then actually for something to satisfy this equal opportunity definition, it would mean that these groups should be predicted the same risk. And actually this would not be fair in this context, since it would mean that we were over or under predicting for each of the groups. But this may be appropriate for other scenarios if the groups have the same risk. And so this is kind of an example of something that may work in some contexts, but not in this example. And another alternative is the equal accuracy definition. And this would say that we want the total percentage of correct predictions to be the same for all groups. And here the correct predictions is the number of individuals that are predicted to have an event, and then they were correctly predicted because they then had an event. And then this is added to the number of individuals who were predicted not to have an event, and then they did not have an event. And this seems like it could also be reasonable. But if we look at what actually happens, so if we see that one prediction here could, on the left, would be that 2 out of 15 people are predicted to have a cardiovascular event. And then on the right, another tool could say that 4 out of 15 will have a cardiovascular event. And then we observe that actually 3 out of 15 have a cardiovascular event. And so here, both of the left example and the right one would have the same accuracy, but actually they're predicting different things. And so this kind of illustrates that this may be fair or it may not be fair, depending on the situation. In this case, maybe we care more about not missing any high risk cases. And so actually we would say this is not fair. But then if we care equally about under and over predicting, then it would be. And so that was just a couple of examples of different approaches to fairness and kind of trying to understand why maybe it's not appropriate to define fairness in one single way, but there's lots of ways that we can explore it. And so now this event is about polygenic risk scores. So I'll just quickly talk about how everything I've said before also can be applied to polygenic risk scores. We've already had a great summary of this, but just a quick recap. So polygenic risk scores are created because lots of tiny differences in people's genes can all be added up, and then they can be used to generate a personalized risk of getting a disease. And these actually can be used in combination with lots of the other risk factors that I mentioned, or they could also be used on their own. And these really are expected to be used in healthcare globally. And of course, they can prevent lots of illness and save millions of lives. However, it's important that they also consider fairness. And unfortunately, at the moment, as was mentioned, genetic data that is used to make these scores doesn't usually represent everyone equally. And this is especially relevant to race, ethnicity, and ancestry biases. And this might mean that the outcomes for these patients would be unknown. And so at the moment, we don't really know how much this could negatively be impacting some groups. And so now, how do we actually fix this? You know, there are ways for it to be fixed, we hope, but it's not very straightforward. And so the first way, if we go back to the causes of unfairness, the first one was that it's because the data is biased. And so what we can do is to improve the data that is used to build these algorithms. And this is really important. And there are people working on this, which is fantastic. And actually, anybody can get involved within these studies. So, for example, there is a study called Our Future Health, and I've just given the web address here, where you can sign up to be part of this study. And what it will do is you'll have a health check, and they will record lots of medical measurements from you and then follow you over a number of years, and then we can see what happens in the future. And these kind of studies are really important for researchers to be able to have better data to make better tools. And also now there is movements towards being able to access an NHS population-wide data. And this would be fantastic, of course, in terms of improving the predictions for these tools, because it does represent society in the UK, and it would be representative of all patients. And so this could really help with improving the tools that we have. However, it is hard to collect diverse data and large amounts of this to really capture everything that we need. And of course, collecting more data doesn't change historical societal biases or inequalities within society. Although I hope that through the work that we're doing in terms of analysing and presenting fairness of algorithms could actually help to expose some of these issues and potentially influence future policy on this topic. And then secondly, how else can we fix this? Is that we can improve the algorithms themselves. And so that's really what we're working on at the moment. And so what we can do is, when you're creating a new prediction algorithm, you can enforce fairness when creating it. And you can do this across lots of different subgroups of society. And the issue with the existing ones is that perhaps these subgroups weren't really analysed in enough detail. But you can say that, okay, the predictions must be equitable across all of these different groups when you develop a new tool. And then secondly, we can actually work with tools that already exist, and then we can improve the fairness of these. And we can do this by actually kind of altering the predictions until they can match these fairness definitions. So to do this, we can do things like re-weighting the prediction, so we can scale up or down predictions for certain groups to improve their predictions. However, it's not always possible to make the predictions equitable, unfortunately, because it really depends on the algorithm and the data that's available. And as we saw with the fairness definitions being different for different problems, it's not actually always clear which ones are most appropriate to use. And so to kind of wrap it up, what is the future of this in fair medical risk prediction? So at the moment, the results suggest that a standard one-size-fits-all algorithm is probably not the best for use population-wide, as we saw the differences in predictions in the different ethnicity groups, for example. And so actually we need to develop probably more tools to make sure that all of these differences are captured. But we can do this. I mean, now we have improved computing power, more data, developments in methods, and research being done into fairness. And so this can help us analyze and improve existing algorithms and create new ones that can combine more data, but really have fairness as a central focus as we develop them. And so the more we study this area, the more sure we can be that these medical risk prediction tools will benefit society as a whole and be able to identify health risks and therefore help to improve healthcare equitably. So thank you everybody for listening to my talk. I'd just like to say thanks to my funders and people who run my PhD program, which is the Wellcome Trust, Health Data Research UK, and the Alan Turing Institute. And then, of course, the University of Cambridge, Department of Public Health and Primary Care for hosting me. And then the UK Biobank, which is the data that I've used for the analysis that I've done. And then also my supervisors, Angela, Mike, and Sam. And so, there's also some information here if you want to contact me in the future, but thanks for listening, and I'd appreciate any questions or feedback.